Hey folks, this is the Click Dork back again. I just got a lot of rest at the Holiday Inn Express the other day, and I feel like I've got a great conversation today. I'm going to share about population and health in general, and I've got a guest with me this time. His name is Jason Wesco. Jason is the Executive Vice President for Community Health Center of Southeast Kansas. Now, before you turn this Dork Cast off, let me share, this is not an ordinary suit guy that we're talking to here. I realize he looks sharp with his tie and his shirt all buttoned up and everything, and that's not your typical data dork kind of guy. But I can assure you, a friend of mine, Carlia Troutman, introduced me, and her introduction was exactly this. This is her quote. "This guy transforms organizations through the use of data." That caught me immediately, because it's like, that's not the ordinarily the thing I see from executives. I'm used to that kind of thing as stats guys or data scientists or data dorks or visualizers things. So, Jason, that's a pretty tough reputation to have to live up to. What does she mean by that?
Well, I think what she means is we're in a high-touch world, in my world, healthcare. And we often think that caring about people is enough, and that, we're all going to go to heaven because we're saving the world here. And my approach has been, okay, so let's prove it. And the only way we can prove it is if we can measure it. And how do we know what to do if we can't measure what we're doing? So I've always taken a pretty analytical approach to healthcare, and it's not easy, because sometimes people in healthcare want to believe that doing right is good enough, but I want to do the right thing and I want to do it well.
Fantastic. So I've got a pretty easy question for you then. How do you do that? Because I was a business intelligence architect in the healthcare space for 10 years prior to taking the job on that I have now. And I had a hard time. I'm going to be honest. That was what I wanted to do, but transforming that culture is tough. How have you gone about, in your role, helping others get on board with your philosophy?
It's a good question, and I'm not sure that every single person is, but I think we've made a lot of strides. Consistently, this seems simple, but consistently being curious and essentially requiring that the answers you get back be data-driven. So don't just tell me what your last interaction was around whatever the topic at hand is, but tell me how you justify your position. And you don't have to be combative about it. I mean, what we're all trying to do here is get people health care. We want people to be healthier, especially in a region like ours, which we'll talk about later. But we have a group of people who really are committed to the mission of the organization. And I think if you have mission alignment first, people will go anywhere if they see value. So my job is to consistently be curious, ask questions, and require answers that can be defended. And, it really does work. I mean, people see value in that too, because what we found is when you publish results, that's the biggest driver to get people to change behavior. So that's kind of been our approach, I guess.
Very cool. So one of the things that I wrote about recently, and I called you guys out, was I kind of felt like federally qualified health centers like y'all have been doing the quality measurement data for a while now, whereas that's kind of a new thing for the hospital and the major health system space, and maybe the traditional physician group practices. And as they look at that, I think there's this look that, oh gosh, it's just another burdensome requirement from the government. How are we going to track that? Are there, I know it's a lot of work to get data. Are there financial incentives to tracking this data and improving on quality?
There are, and they're coming. It's becoming much more frequent as we hear about pay for performance as opposed to being paid for widgets. But something I think that's important to know about community health centers is since the 90s, we've been paid differently, particularly by state Medicaid programs. We're paid an inclusive rate, an encounter rate, essentially the same amount of money for doing whatever we do to people, not to them, with them, for them, however we want to approach that. And what that does, that's payment system reform that has happened far ahead of everybody else. And what it then encourages is a holistic approach to doing the right thing for the patient as opposed to ordering 5 more things that make me more money. So since that period, Medicare has switched to this prospective payment or this all-inclusive payment system for us. So now the majority of patients we see, we are paid a fixed amount regardless of what we do, which I believe encourages us to take a more holistic approach to their care. We're not paid by the widget. We're paid differently. So just as background, that there's kind of this structure behind us that has always viewed healthcare from a population perspective. And now what's happening is commercial payers are starting to provide incentive-based payments for outcomes or lowering cost. So I would imagine we're not too far away from every patient we have, except for our uninsured patients, having some form of incentive attached to their care.
Good. That's great to hear, and I definitely am a firm believer in that as well. And glad you mentioned that there is the financial incentive, because I think for some, it's going to take that, right? There is the grandiose idea of, hey, we're improving healthcare, but understanding that it does cost money, and you can fight this or you can get on board, because then you are going to be financially incentivized and you're going to be helping healthcare. So whether you're the financial guy or the healthcare guy, you should be happy about that. So when I reported the numbers, it was like, wow, they're improving, over 2012 to 2013 to 2014 to 2015 to 2016 numbers just came out about 2 weeks ago. I pulled those down. I couldn't wait to pull those numbers and write to you and Caroline and say, oh my gosh, I'm so glad you guys jumped from 74 to 85 to 99, and I saw this 14.29. I'm like, oh my gosh, this group has totally let me down. When I look at immunizations there, what happened, man?
Well, we are measured every year through a system, the federal UDS system. The data is out there. You've seen it. It's great data. There's access to a thing called the UDS mapper where you can map a lot of this data. And what happens every year is either new measurements are created or old measurements are adjusted to include other requirements. And so, it's not like we went from 85% to 14%, the measurement changed. Our kids are still getting immunized at rates that we're very proud of. It's just what is included in that measurement and exactly what shots do all of our kids by the time they turn 2 have to be a plus in that bucket. So it happens. It doesn't look great, but, our kids are still getting the shots they need. They just may not be getting 2 flu shots by the time they turn 2. So that's kind of what is up with that.
Yeah, I kind of picked that one because I knew it had changed from 3 to 2. Is that hard? Like I'm a guy who likes to set goals. I like to see improvement. Was it hard? I mean, just being honest, was it a hard pill to swallow just to see a number from 85 to 14 when you know that the measure changed? Is that a hard thing to do when you're so focused on improving and you've had such great success to see that number drop like that, even though you realize the measure changed? Sure.
I mean, clearly it is. It's published data for everybody to see, and we've always prided ourselves on the care we provide to our kids. So it is, but when you've got a system as large as ours, I mean, we have, for a health center, we're relatively large. We have about 300 staff. We've got about 42,000 patients, 12 locations, multiple locations in 5 counties. And you don't just flip that system overnight and say, hey, everybody, the measurement changed, and here's what it is now. And, things just don't happen that quickly. When you've been focused on a target for so long, and I can tell you, I've got an almost 2-year-old, and getting that second flu shot for those babies is nobody wants to do that, So we feel very strongly that our kids are getting immunized with all the stuff they need. We know that number is going to get better as we align that with our metrics and strategy and all that sort of thing. But we still know that our kids are you don't just get that bad that fast. It's a numbers thing.
Fantastic. Did you, in any way, shape, or form, internally show people the metric based on the old values to show them, hey, here's what our number would have been had it stayed 3 years old? Did you do that internal calculation just mentally in your head, on paper, but mentally as a practice just for people, other people like yourself internally, to know, hey, that number really would have been something better than 85.71?
Yeah, it's a little bit better than 85.71. It wasn't dramatically better, but we're really proud of that number because Kansas in the country, I think we're 48th. We're in the bottom handful of states in immunizing our kids for lots of reasons that we don't need to necessarily talk about. But in a lot of areas, we're twice as good as the state average in the poorest region in Kansas. So we've been very proud. We're still very proud of where we are. We just, have to recalibrate a little bit. Yeah,
and that's I was thinking internally. I would just need to know what the number would have been to make sure that our programs are doing the right thing. We're getting that communication out. And in fact, I pulled the numbers and I ranked them, and you guys are ranked very, very high in that within Kansas and within the country in general. One of the things that also was out on that reporting site I noticed was some recognition awards. You all won a number of financial awards, one of which was a National Quality Leader Award. Can you tell me a little bit about that?
Yeah, there are, and I don't know the exact number. I think there were somewhere around 40 of these awards made, and I think there are 12 or 1,300 health centers in the country. So only for those who are the highest quality across the board for the greatest number of patients got that award, and we were the only ones in Kansas to get it. And as you can see, it's not a small amount of money. So we were very proud of that, and I think that probably goes to show, on balance, immunizations aside, that we're one of the highest quality providers, in the community health center world or the FQHC world in the country, that'll make you pretty proud.
Yeah, and exactly, and I kind of wanted the disparity of those two things, because as people are tracking numbers, that was always my most frustrating thing, was you can't tell me to give my heart and soul to something and then change the measurements on me. That's not fair. Create a whole new category, but let me still see the improvement. This, I think, I kind of wanted to balance it with that hey, that the numbers did change, and you guys did improve in so many other categories. And we're so far out in front within Kansas. For those of you who may be watching this, if you see this website, all you've got to do is change these last two to the initial for your state, and you'd be able to see what was going on within your state in terms of these as well. And in my blog, I've mentioned that UDS site where I pull the data from that I showed. So I asked Bob Burke from your organization to send me a few pictures that might be able to use to kind of spark some conversations. And he sent me this, and as a data guy and a visualization guy, I absolutely fell in love. It's like, okay, this is the first picture I'm going to talk about. It's a dashboard. So tell me a little bit about this and where this thing is located.
So this is what we call mission control. It is a centralized communication center that's located in our largest community that we serve and kind of our hub here in Pittsburgh, Kansas. And we use this every day. The communication center has been operational for almost a year now, and all the phone calls that come into our organization in a day initiate in the communication center. So if you call a clinic in Independence, Kansas, the phone call rings here in Pittsburgh, at least initially. So we thought it was important to have a visualization for the staff in the communication center to see some different metrics around things that we think, at least in the first year of operation, are important. And so that communication center, the entire point of it has been to better serve our patients in a more targeted way, get phone calls answered more quickly, get them clinical answers more quickly, because we have both schedulers, registration staff, and nurses that work in the communication center.
Cool. And so he sent me the picture of this. This, I guess, is that control center area.
Yep.
And I'm envisioning they're taking calls. Hey, did my results come in? They're taking calls to do scheduling, that kind of thing. Is that what they're doing?
They are, and you can see just in some of those pictures, there are 3 monitors. They have headsets. Everything they do is clicks, so they know from where a patient is calling. They know which number a patient dialed. So they have some pretty good intel. But yeah, they're making appointments primarily. We restructured our organization so that all of our appointments are 20 minutes long across the system, across providers. So you'll walk through there. They'll be making dental appointments, behavioral health, medical, across the system, and also doing outbound proactive population health related calls about getting kids in for well child visits or dental visits, or you name it. There's a range of things that we do on outbound calls from the communication center.
Fantastic. So for those who aren't familiar, this was something I had posted this in my blog. This is basically a visualization of the locations for Community Health Center of Southeast Kansas, the different locations, just so you could visually understand where the areas are. This is one of the things, and we're going to get into this conversation a little bit in terms of population health. This is one particular CDC social vulnerability indicator, and I kind of wanted to highlight this not just to show you the areas, but bring it up now at the point of the time we're at, while we're watching devastation happen in Houston. This particular data set that I use, and I use it often, I talk about it as social determinants of health. It was created for situations like events that have just happened in Houston, where the government needed to know where are the people are at risk if this happens and this happens and this happens. And that was exactly why that particular data set was created, which I love using. So I kind of wanted to bring it up. This particular one was about income that I used in my article. But if you were to look at this as coloring and say, hey, here's the areas that have the most people without vehicles, that would be your risk areas when a flood comes and you need to go rescue, or where the disabled people are in blocks. So this particular thing was about income, and it was used for a point as to where Jason centers are located. And so this is one of the centers. This is, I guess, your Pittsburgh location?
It is, yeah. And that initial building, the building there to the right, was the initial 15,000 square foot clinic that was opened in 2007. And the addition to the back was added in 2015 with a significant grant through the Affordable Care Act. So we now have about 43,000 square feet, and the building behind it is the system office where administration and the communication center are. But altogether, we have 62,000 square feet of space in a town of 20,000 people.
Fantastic.
A significant clinic, and as we'll talk, it has just about every service line you can imagine available within.
So the particular town that this was located in, you say has 20,000 people?
Yep.
About how many of those do you serve?
We have a little bit. I think we're right about 9,000 patients out of the 20,000 residents are our patients. So almost half of everybody in town's our patient in one way or another.
Fantastic. That means you're actually reaching the community. We're going to get there in a second. Here's another one of your campuses, just for kind of a different visual there. And what I kind of loved about this particular picture was this great, big, huge sign reminding people how to call and get appointments. That is not something that I see at other locations. I mean, that is a pretty predominant sign making things easy for this population to reach. And when you are reaching into the community and you are the health system, and you will be going through some of the different things you do, I thought that was pretty significant. So I thought that was neat. This is another one of your locations. Do you know what location this was here?
Yeah, actually, that was that was kind of the second location we ever had. Believe it or not, that big sprawling campus you showed a couple of clicks back started in that little trailer. So and so is this now replaced, or is this just a different location? That building has now been moved. It's now an early childhood center in our community, but it's where it all started, and we were incredibly proud to have that, because before that we had a fifth grade classroom in a school building that was built in the early 1900s. So moving into a 1,500 square foot trailer, I mean, we have, our lobbies are bigger than this building, but there are still 24 of the 300 people that work here that worked, including me, that worked in that trailer, or worked here when we had that trailer. And so it holds a very special place in our hearts.
That's very cool. And again, one of the reasons I picked this was just for those of us who go to mainstream physician practices with marble rotundas and huge, gigantic waiting rooms with fish tanks and LED screens hanging all over the walls. I just wanted to kind of bring this out. This is kind of, I wouldn't say hardcore. I would say this is healthcare in a way that we haven't, a lot of us at my end haven't seen before. So I thought it was pretty neat to realize, and especially to see that appreciation as you move from a classroom to a larger facility, the impact that you can have on the community, and the fact that it's focused on health. It's not focused on aesthetics, beautiful parking lots. It's how do we help people get healthy and stay healthy. So one of the neatest pictures, I'd asked him, send me pictures of like the community. Let me know the kind of people that are around town, going through the streets. And he sent me this picture, and I was like, I've seen mining towns, but they would at least have modern clothes on. Unless these miners are like borrowing clothes from their grandfathers, this is probably not recent. So tell me a little bit about this one, Jason.
Well, this is a photo that we use quite a bit in our history here in Pittsburgh. It goes back to the late 1800s when folks were looking for cheap fuel sources to smelt heavy metals. So south of us, southeast, southwest of us were lead, zinc, big heavy metal mines, and they needed cheap sources of fuel. And up here in Pittsburgh, we had coal, bituminous, dirty coal that was really cheap. And so then began the boom from the mid-1890s through probably the 30s. We had huge population influx from largely Central and Southern Europe, about 35 different languages spoken here. Obviously, it's worked. It's not very safe. It's not very steady, but it brought this incredible culture to us that survives to this day in its positives and negatives. So we live with generational poverty here. We live with poor educational attainment, poor health outcomes. Across the board, the 9 counties of southeast Kansas generally rank in the bottom, easily in the bottom quartile, many in the bottom 10 in for health outcomes and health factors. So it's a wonderful place to live because those same folks brought a lot of ethnic diversity, a lot of Italians, just kind of a very work hard and play harder culture. But we've always believed it's very important for us to be successful in intervening. We have to understand the community in which we operate and the community in which we live and work. And you can't do that unless you know the history and how a thing got to be the way it is.
Very neat. So one of the things that I would think, and this was one of the interesting things watching your quality numbers go up, there's one thing to convince the healthcare workers, the clinicians, the registrars to care. The other, I think, is this cultural thing. You've got such a hotbed there, and the man's man doesn't want to go to the doctor unless they're dying.
Right.
With your numbers going up, you've had to have impacted that culture. And with 35 languages, I'd imagine there's 35 different perceptions of healthcare. How have you managed to reach out to the community and let them know that you really are there for them and try to figure out, okay, if you've got a problem with this, how can I get that same thing done for you in a way that won't offend you or hurt you or would be acceptable? So what are some of the things that you've had to kind of do to bridge those cultural barriers?
Well, one, we are of the community. I mean, we're a community health center in the absolute purest sense of that word. One of the requirements for community health centers is that you have a patient-led board, and we do. But we're people from here. So there's nothing being done to anyone. It's being done with them. So our healthcare providers, not all of them, but many of them are from here. Our staff are from here. So inherently, I think we understand how you operate in this environment. And one of the ways you operate in this environment is you last. You just stick around. Because we have so many hospital systems that, bring doctors in for loan repayment and they're gone in 2 years. And there's no sense of continuity or consistency. And we've just kind of been here. And I think probably after year 9 or 10, we probably hit a tipping point where people all realized, these people are here, I can trust them. So it took being consistent and being here, I think, and a consistent focus on what else can we do. So we started with medical care, then we did behavioral health, then we added dental, then we added pharmacy, then we added patient navigators. So we're out and about and in the community and doing things all the time. And I think it gives us lots of opportunities to demonstrate to people that we really are different, that we really do fundamentally care about improving the health of the communities where we work, that's not just words, that it really matters to us. And so I think that's what's led us to where we are today.
That is phenomenal. I want to focus on two things. I want to get back to that. The statement, it's not what's done to them, it's done with them, I think is huge. I think is kind of a change of a philosophy. So I hope people caught that. The other thing about being there and being consistent, one of the things that I had wanted to get to at some point and maybe at the very end was as hospitals and these large, gigantic health systems are finally going to kind of be forced to go to this model, I think it's important. If any of you are listening, for goodness sakes, understand you're not going to get that kind of adoption overnight. And instead of looking at doing everything from scratch on your own, as you start thinking about how do I do these social services and how do I get patient navigators, for crying out loud, reach out to the Jasons that are in your community already. They're already there. They get the idea of these patient-led boards. Reach out to them and partner with them instead of trying to go it all on your own. Learn the lessons that are shared because you have a completely different operating philosophy. And this is not something that you're going to be able to do overnight. I've had some things shared by some others that I'll probably be blogging about soon as to what they've had to do in their communities. And those are not things, like Jason said, though, that just doesn't happen overnight. It's not, okay, the last week we are out to guard you, now we actually care about you, please listen to us. So I think that's huge. So I really appreciate you bringing that up, and I'm still just overwhelmed with it's not done to them, it's done with them. That's pretty neat. So send me this picture. This looks like a traditional type of a patient with a traditional type of a doctor. So there's like typical healthcare type stuff, like this. It looks like an office visit kind of a thing. And then he sent me this. It's like, this isn't something I see at my typical doctor's appointment. So you guys obviously provide eye care as well?
We do. We do that in Pittsburgh and some of the other clinics through agreements. What we realized, again, back to the way data drives the organization, is that two populations were not getting vision care that they needed. One were kids. So the majority of our kids, by the time they get to school, have not had a vision exam. They've had a screening, but not an exam. So that was a driver. And the second was we have, given our population and our focus, a couple of thousand diabetics in our care and consistently had issues getting them eye exams. So we started a 2 to 3 day a week, depending on the week, vision clinic here in Pittsburgh to make sure that there were no barriers to anyone receiving vision care, but specifically our kids and our diabetics.
Neat. Very, very nifty. And then this is an unusual office visit. They're not immunizing through the mouth. I'm guessing right. This is dental. So you guys actually provide dental care as well? Yep,
have a large and very busy dental practice. This was actually part of our dental outreach team. We have 14 dental hygienists on staff that go throughout the region and provide screenings. Last year we screened 32,000 kids in southeast Kansas in schools for oral health problems. And we also provide cleanings, fluoride, preventative treatment, and in a couple of counties we send a dentist into the schools to do restorative work. We were part of a 5-year NIH study in 2 of our counties about outcomes for kids in our oral health program, and what we saw that was really, humbling is that the more times we saw those kids over 5 years, let's say we saw those kids every year for 5 years with preventative care, their instances of decay didn't go down, meaning they weren't getting to see a dentist to get the work fixed. So that's why in those 2 counties we chose to send a dentist out to do work. So we have a huge footprint in terms of outreach in Head Start, WIC, Women, Infant, and Children clinics, and in schools in addition to our fixed dental clinics. So we do a lot of work beyond the walls of our facilities.
Very cool. If I couldn't admire you anymore, my wife is a dental hygienist, and this is her passion.
She would love to see what we do here.
Yeah, absolutely. Yeah, that's kind of her thing. So yeah, that's I know she's going to appreciate hearing what you guys do with that. This was interesting. This looks like a funny place for people to come to get checkups.
Yeah, we use this every day. The foundings of our organization were really based around making sure kids are ready to learn. Unfortunately, the health factor that creates so many poor health outcomes, that is consistent across the 9 counties for us is child poverty, and it's only gotten worse in my time here. So now at least half, in some counties upwards of 60% of our kids are born poor. And so we made a commitment early that we were going to make sure we focused on kids. And one of the ways we do it is school-based health services. And here in Pittsburgh, we have 4 elementaries, a middle school, and a high school, and this bus goes to all of them once a week and takes a nurse practitioner right to the school campus. So we realized that to get better, we had to get our kids better, and to get to our kids, we have to go where they are. We can't expect them to come into our clinics. And we're seeing measurable results that even though we're poorer than we used to be, our kids are healthier than they've ever been.
That's fantastic. And one of the things when you mentioned the generational poverty, you also mentioned education. I think it's such a crazy catch-22 that we know as a country. Kids who are hungry can't think. Kids who are sick can't think. And so that just stays a cycle. I think there's definitely social things that we could do as a country, and this is absolutely one of the areas that I believe in highly. Is we've got to make sure the kids that are in school are fed and don't have to be starving, and so their brains can work, and they got to be healthy. And so reaching in, I think, is helping you probably in the long term. I'd love to see the numbers that come out 10 years from now in breaking that generational cycle. If we can keep the kids fed, keep them healthy in school, they can learn more. As they become more educated, they're going to break that cycle. So I admire that. I think it's a neat looking bus. Kids gotta love seeing that thing come rolling in. So I think that's a great thing. One of the things I saw on Twitter once I started following you guys was this picture of Mallory, and she was given a title of Director of Population Health, which is something I see so infrequently anywhere, let alone for an organization you guys size. So tell me about this decision to actually have this position of a Director of Population Health.
Well, it's something that we think we've always focused on, but we've gotten to the size now where we need really, kind of a hub for all of that information. So what we're seeing, to your point earlier, we have more and more payers sharing more and more data with us. Some of this data is amazing, real-time claims data. So we know when our patients go to the hospital or the ER. And with one particular payer in specific, and I won't mention who it is, but we've been working with them for 3 or 4 years, and our question to them is, how are we doing? What's our medical loss ratio? You hear this number a lot. So for every dollar you're given, how much of that dollar do you spend on health care for our patients? And our number was so low, we were like at 67%. And their goal for their population is somewhere just under 90. So they had incentive programs to get people to 90 or 85, and they do shared savings. But we were so low, they couldn't figure out a way to incentivize us. So I just said, well, would you give me money to hire somebody to work on this kind of stuff? And so that's what they did.
That's awesome.
Yeah, and so what we're seeing now is more and more payers, when we go to them and say, hey, what's my medical loss ratio, they go, oh my gosh, you guys are like the best deal in healthcare. So we're looking for ways, because we obviously are making third-party payers money. If payer X is making 35 cents on every dollar for every patient I see, and everybody else in the community is around 90 or 100, they have a strong incentive to get patients to me, which works for us. So the volume of that communication and those contacts is getting to the point where, we've got 4 different payers sharing data with us and working on projects, and it was just overwhelming. So now we have somebody, really it's an analytic position. It's it's some population health positions, if you see them, are really focused on like case management and care coordination and all of that. We're starting more from the analytic perspective of, if I can get my immunization rate better, that's good for kids. It also might be good for us financially. How do I manage that, manage the work process, get the information out across, a relatively large primary care organization?
Fantastic. It's so neat. And I kind of ended with this simply because I figured that would kind of tie a bow on this. I started a series on population health a while ago, and I figured this would be a kind of a good way to wrap it up. Jason, I can't thank you enough for your time.
Sure.
I know as an executive vice president, you got more than enough things to keep you busy. And being on a Dork Cast isn't one of those things that help pays the bill. So I appreciate your sharing. Hopefully for those who've been following the blog and who sat through the 40 minutes of this Dork Cast, it's been helpful for you to understand not only community health centers in general, but this idea of population health and getting a picture of this. When I write about social determinants of health, or what's kind of being changed now to the term social influences of health, what that means. That means that it's generational poverty. It's a culture of not being healthy and not being educated, and breaking that is tough. And those things definitely influence outcomes. And it takes somebody like this, who's data-driven, to change it and say, look, it's one thing to say we want to help, but it's a different thing if we can show numbers to prove that we are. And there's also financial incentives there to actually make that improvement. So appreciate your time, Jason. Anything last you'd like to say about Southeast Kansas, or anything else you'd like to leave with? I'll give you the last word.
Sure. Well, I think there's no one who would believe 15 years ago that we would get to where we are today with 43,000 patients, 150,000 visits. And we've done that by believing something very simple, is that our job here is to heal people. And we're transforming the way healthcare is delivered. And I want people to understand that maybe not every community health center is, but many are. And just because we provide care regardless of whether you have a piece of plastic in your pocket or not, don't ever assume it's somehow lesser quality of care. You've seen today, as we've talked about the complexity of what we do, medical, dental, behavioral health, pharmacy, all of that. We only do that because we want to touch people in our community as much as possible and help them, because we've been behind for so long that we think it's about time that our patients get the best of what's available. And we're incredibly proud of it, and we're incredibly proud to talk about it. And I'm glad that you are interested and wanted to have this conversation with the folks that listen.
Fantastic. Couldn't have said it better. Have a great day, everyone.